Tibial plateau fractures, a soft tissue injury if to 90%. Blood supply, posterior tibial artery. A periosteal circulation from anterior tibial artery. Lateral tibial plateau is convex and medial tibial plateau is concave. Medial is more distal, aware when putting screws. Three-column concept, medial column, lateral column, and posterior column. Schartz curve classification 1 to 6. Indication for open reduction internal fixation. Number 1, depression of the joint surface equal to the depth of cartilage. Number 2, medial fracture. This can lead to varus collapse. Number 3, bicondylar fractures. Number 4, posterior fracture. It causes instability in flexion. Number 5, varus valgus malalignment. Number 6, condylar widening. Principles of fixation. Number 1 is the goal is to restore normal alignment and bicondylar width. Number 2, restoration of articular surface is secondary importance. Number 3, soft tissue management. Number 4, restoration of length, alignment, and rotation. Number 5, repair menisci. Number 6, early range of motion. Number 7, stabilization of all the three columns. Posterior medial approach is supine, sandbag beneath the contralateral buttock for medial condyle towards posterior medial edge of tibia. Internal is between pes and serinus and medial head of gastrocnemius. Anterolateral approach. This posterior is fixed with a T-plate. Anterolateral approach. Better soft tissue coverage. 1 centimeter lateral to midline, just anterior to the Gerdy's tubercle. Straight or hockey-shaped incision. Split tibius anterior from the tibia. Horizontal incision under the anterior horn of the lateral meniscus, submeniscal dissection, sutures, elevation or an exposure of the lateral tibial plateau, and then raft screws after K-wire. Midline incision can lead to significant soft tissue stripping and should be avoided. And posterior approach. Principle of fixation, restore the joint line stability. It is a stronger predictor of long-term outcome. Number 2, restore from below. Anterolateral or medial metaphyseal window for pure depression type. Temporary K-wire fixation, bone graft or bone graft substitutes. Calcium phosphate has high compression strength, can be placed over there. Compression with a lag screw act as a subchondral raft to support depressed fractures. Repair associated ligaments, preserve menisci, restore mechanical alignment of the tibia. Screw can be used alone for simple split fractures that are elevated percutaneously. Better to buttress if depressed. Type 4 associated with coronal split require medial and posterior T-plate fixation before contemplating. Examine for stability after fixation. X-fix ligamentaxis, 2 pins in the femur, 2 pins in the tibia. Avoid zone of fixation, not zone of injury. Avoid zone of fixation. Complication, lateral meniscal injury, medial meniscal injury, osteoarthritis, post-traumatic arthritis, ACL injury, common peroneal nerve injury and artery, compartmental syndrome due to extravasation of fluid during the arthroscopy, so avoid pressure pumps. Arthroscopy is to assess the reduction of articular surface to check for soft tissue entrapment. MCL most likely to be injured than LCL due to direct insertion on plateau.